Hello and welcome. And today I'm very pleased to be joined by Lauren and Kate. And what we're going to talk about is something maybe slightly different from what we normally talk at My Health Focus, but absolutely relevant to what we do. And it's all about trials. And so the actual title for this is called Beyond Access: Uncovering Hidden Public Health Benefits of Participating in Experimental Medicine Trials Through the Detection of Clinically Significant Findings at Screenings. Now, what that all means in a nutshell is that when you join a clinical trial or you try to go on it, the first thing is quite often you have a lot of screenings. And those screenings are very important and they can provide some significant benefits in a minute rather than me gabbling on as usual. But to explain how important and how significant the finding of this research paper has been. So welcome, Kate and Lauren. And Kate, if you'd like to kick off first explaining who you are and why we're talking about this paper.
Thank you. Hi, so I'm Kate Dodd. I'm the Recruitment and Engagement Manager at Liverpool's Clinical Research Facility, which is based in the Royal Liverpool Hospital. I am currently doing a PhD study and looking at how we can make clinical trials more accessible to all communities. And part of this is this current study, which we'll discuss shortly.
And I'm Lauren. I'm the Deputy Director for the NIHR, that's the National Institute of Health and Care Research, funded CRF, where Kate is the Public Engagement Manager, and I'm Kate's supervisor for her PhD.
Excellent. Okay, so to kick off, what does screening involve? And I know one of the standard things, or the message that they always put is there'll be no direct benefit for going on this trial.
So do you want me to take the clinical part first? Yeah. So a screening is when we determine whether or not you're eligible to take part in a trial of a new medicine. And that eligibility means, do you meet the criteria that we've set out that mean we can get the answers to the questions we want but keep you safe at the same time? So in the NIHR Liverpool CRF, we do a combination of trials in healthy people and trials in patients as well. So we do what's called the early phase part, which is where medicines have been developed originally by a company or by an academic group in a laboratory, and they're then being tested in human beings for the first time. That's our part. And so for healthy volunteers particularly, quite often the information that's given to them is that you won't directly benefit from being part of the trial. And that's true in the sense that you don't have a health condition for which that medicine is being developed. But benefit takes many forms. And so where I agree you may not, you're not going to benefit from the medicine that's being developed for, if it's a new medicine for diabetes or high blood pressure, for example, because you don't have those conditions because you're healthy. You do benefit by having a health check, what I refer to as kind of a health MOT, because as part of being, studies involve us checking out all of your organ systems. So we need to make sure that your kidneys are working fine, and we need to make sure that your liver is fine, and that your heart is fine, you haven't got any funny heart rhythms, or there's no issues with the structure, that your blood pressure's okay, that your waterworks are working fine. So a full kind of 360 MOT of your general health, because that's the only way we can say you are a healthy volunteer. And I can sign you off as a physician and say you're a healthy volunteer, is through doing all of that. So that in itself is a benefit to any individual, but a particular benefit to people who perhaps have more difficulty accessing getting a health screening. So some people work in companies where they get an annual health check, and some people live in areas where there's very few people to the GP ratio, but for others that's not the case, and it's more challenging. So there is a benefit, even if you're a healthy volunteer, to having that health screening. And then also we do patient studies as well. So we'll involve a group of people. If we're developing a new medicine for diabetes, then that might be a group of diabetic patients. And again, they undergo all of that screening that's quite intensive. So we might find something that's not related to their diabetes, actually. So that's the benefit that we're talking about here.
Yeah, and I have to say, and I know I said this to you earlier, when people ever say to me that a doctor has suggested they go and have a test, I always say, go and have that test, because you never know what they might find. and I think it's always positive. And then we all know how hard it is to get to see a doctor, let alone to be offered the tests as well. So, what prompted the research?
So because we recruit, as Lauren said, a lot of healthy volunteers and patients, we've seen a couple of case studies whereby patients have been identified as having a medical condition that they previously didn't know about. And we wanted to be able to quantify, so be able to tell people how often this is happening and to share that information, because we feel that when patients or healthy volunteers are taking part in clinical trials, we need to be very open and upfront about what might happen as a result of that trial. And that includes, well, we might actually find something that you didn't know you had before, because that would put some people off. When we did the community engagement work, which we'll discuss later, it did come across that some people wouldn't actually take part if they thought they might have something identified. But that's a small percentage of people. There are lots of people who would be very pleased to find out that they've got something and detect it earlier, because obviously the earlier we detect problems and medical conditions at the very, very early stages, the more likely we are to be able to offer treatment earlier and to reduce the complications that brings in the future for the individuals.
Yes, and I think that it is giving people a full rounded understanding of the fact that you might find something that you didn't know about, and to understand for some people that would be something that they don't want to know about. And I think that is important to strike that. I mean, in your research, I know you give two examples of, if you'd like to give the two examples, which I would say would be a real plus, that were found for patients.
There was one that we found latent TB and hepatitis B, and there was another one where we found another hepatitis B, and then the last one was the Wolf-Parkinson-White condition.
So some quite significant infections that are treatable, that where there are medicines and it's really important that we can treat those, that they're transmissible, so they can be passed to other people. So again, really important that we treat those. And then the last one with the funky name, so Wolf-Parkinson-White is a cardiological conditions, so something that affects your heart and increases your risk of having a funny heart rhythm that could put you at risk of harm. So again, really important to know that you have that, because it can be treated. And so they were for all of those individuals, they were referred on to the appropriate specialty for treatment. So those were quite significant kind of health issues that we identified, and that was kind of what prompted the study generally. Is Kate and I talking about that and saying, gosh, if people knew that was that was potentially something that might happen as through being part of a trial, wouldn't that help to help people to realise what that that's a tremendous benefit, because they may have gone for many years actually, because if they'd never gotten unwell in any other way, they might never have identified those things. So
and how did you establish those findings? Because I know that you went back over a significant number of years looking through people's records.
Mm-hmm. Is it 5 years? Did you do 5
just
years?
Over 5 years. So we went through all of their records, and we pulled off everybody who had something identified. So there were quite a lot. I can't remember the exact number, but there were lots. And then what we did is the medical team here, led by Lauren, reviewed all of the patients' records to see whether it was what we call a clinically significant finding. So basically a finding where actually something needs to be done about it. So a referral or advice about lifestyle choice. And then you all reviewed it, made sure that they were definitely clinically significant or not. And then those that were clinically significant, so those that needed further, support, we then categorised them into different organ systems, as Lauren described it before. And that's when we were able to see, well, the percentage of people who had, say, high blood pressure and needed treatment or monitoring, and those that had high lipid levels, so high cholesterol, that needed some sort of, review and maintenance, really, with those conditions.
And it may sound like a stupid question, but how did you know that it was specifically by being on a trial that this was identified?
So generally speaking, the majority of conditions, as Kate says, were cardiovascular or cardiometabolic. So they are related to your blood pressure, related to your lipid count, related to maybe something happening with your liver, getting a bit fatty. That they're asymptomatic conditions. So what we mean is that you don't know that you have them, you don't feel them, they don't give you pain, they don't. So you would only know that you had them if somebody deliberately checked. And so we do monitor people's blood pressure as part of the screening process. So we take a level while they're here with us, and if it's high, sometimes it can be high because it's stressful being screened for a study. So then we would arrange for them to take their blood pressure at home, or go to a pharmacy to do it, or have it done in their GP practice. So we've got a number of different measures. So we know it's not just a one-off, it is a persistent high blood pressure. Similarly, for cholesterol, if it was identified to be high on a random sample, then we would have arranged for them to have a fasted sample. So come back for a blood test when you've not had anything to eat after 10 p.m. the night before, to make sure that it's a real thing. But yeah, the reason we know we've identified it as part of the screening is that it's not part of their general practice record, so the GP wasn't aware of it. As part of screening for trials, particularly for healthy volunteers, is that we also need to look at what existing conditions individuals have. So we knew that these were new conditions, that they didn't have any symptoms from them, and therefore they could have gone for many years without ever knowing. And the really important thing for things like high lipids and high blood pressure is that these are risk factors for subsequent events happening later in life. So we know that people living with high blood pressure, living with high cholesterol, are at a greater risk at a population level of having something like a heart attack or a stroke. So the earlier you know about it, the quicker you can do something about it, rather than perhaps living with it for 20 years in a silent fashion that you never knew, and that year on year, that risk of a bad event like a heart attack or a stroke is increasing.
I mean, this obviously was done in very much a localised area, i.e. Liverpool, and obviously I know that at your centre there's particular things that you're particular treatment areas or conditions that you look at, but obviously the tests that you're doing are quite generic and could apply to anything. How do you think that the sort of, if we were saying that, I don't know, whatever percentage numbers of people that you ended up with, and I know we'll probably discuss that at the end, of finding issues, would that, do you think, be replicated across the whole of the UK, or do you think there's something unique to the Liverpool area?
We've presented this study at a couple of meetings now, and the general conversation is that people do see these kinds of underlying conditions recorded across the country. It's not just a Liverpool City region thing, if you like. And what the other sites are thinking about doing is this similar study, so recreating this study with their populations to look at whether the percentages and the findings are the same. But we will never know that until these studies are done. But for us, these are our figures. But there will be definitely findings across all clinical research facilities. It's not new.
They just might vary slightly in terms of the nature of the conditions that are identified. We probably have, there will be unique things to the Liverpool City region. It's a more deprived part of the UK, some of our kind of catchment, but equally many of our clinical trial participants come from the kind of higher income or aspects or parts of the region. So I do think it probably is. It's a mixed bag and it's broadly representative, but there will certainly be more ethnically diverse areas of the country where they may find slightly different things. But I think it's really, it's a big enough sample size to suggest that this is definitely worth doing in different areas.
And I think also what was interesting, looking at sort of the ethnicity of your groups, I mean, it was quite high for white Caucasian. The area where you are, there is a lot of mixed communities going on, and I imagine that the more that one can go in it, the higher you would find some of the incidents of the issues that came out from it. So clearly what we're talking about is a benefit, and I know people are really careful about using the word benefit in terms of trials. So how would you go about trying to explain this actually is a benefit, but actually not make it seem as it's an inducement to participate in a trial?
Yes, so all clinical trials come with a patient information leaflet which describes what's going to happen, what the study's about, what the risks are, what the benefits are, what we do with your data. And it's a very long document, and that's another piece of work and another conversation for another day. But what we would like to see is this data put into the information leaflet in a way that's understandable to everybody, so that they're aware of this as a potential, benefit or outcome of being on the trial. And we'd like to be able to tell that to participants, and that's our ultimate goal. And it's about being, it's like you say, it's not about being coercive, it's about being able to be open and upfront about what will happen to them on the trial. And one of those things might be that we identify an underlying condition. So we talked about some of the examples earlier that we found. We also had one gentleman who we found to have lymphoma, which is a form of cancer. And, some people, if you mention cancer, would not want to come on a trial and the chance of finding that. But this is, we need to be open and honest. We need to be able to say, we may find findings that potentially can impact your life.
That actually takes you onto a far bigger conversation about health, and that putting your head in the sand doesn't make it go away. And the more we can be proactive towards our healthcare, the better, really. I mean, have you spoken to HRA to talk about this? Have you gone through any of those loops yet?
So we've had, last month, we had our initial discussions with what's called the Phase 1 Advisory Group, and this is part of the HRA, it's led by them. And they have clinical research organisations on there, such as pharmaceutical companies, representatives from other clinical research facilities, HRA representatives and ethic committee representatives on there. So we presented the findings along with the community engagement work that we've done following this paper, and we presented the findings, and we're hoping to have further discussions with them over the coming months.
And I suppose, it then starts looking at what are the legal obligations of the sponsors when they find that, if they find something.
Yeah, I suppose so. I guess it's that it applies to everyone, doesn't it? Regardless of whether you're a drug company making a new medicine, or whether you're an academic group, a university group who are wanting to test a medicine or a device or a biomarker or whatever, that the process is the same. The individuals that are going to participate are going to need to be screened to ensure that it's safe for them to participate. So I think it's something that affects all of us. It's not necessarily a thing that is only relevant to drug developers. And I think what we found from that meeting is that everybody agrees that more specificity is helpful. So rather than just say, as part of the screening process, we may find something with your health, it's always much better to be able to say this is the, a study has shown that. Is it 6.5%?
So for healthy volunteers, it was 6%. 6%. For patients, it was 4%.
That it's in that region, and maybe something that's a helpful, because we're often very conscious of kind of how we communicate kind of complex information. So maybe having what they call a Kate's plot, the ones with the smiley faces and sad faces. So if you can show 6 faces out of 100 faces are the ones, it's easier for individuals to say, okay, so it's not likely that there's going to be something wrong with me, but it's possible that there will be something, and I would rather know than not know that might be something that can be treated. So I think there's an obligation for all of us to be more, as Kate says, more transparent about what the likelihood is.
But as I said, I think it goes on to the bigger thing is, once something's been found, is it the responsibility? And I know we can't answer that now, but, how far do you take that responsibility of being A, the research organisation, or B, the actual sponsors of it? And having a clear pathway at the beginning is obviously very helpful so that the patient knows which way to go. And when I know that the other sort of bit of the section was you were testing the wording with the public. And that, I thought that was quite interesting. And it's what came out from that process.
You see in the publication is an initial statement that was developed by the research team along with our patient and public involvement group around that wording. But we felt that the wording was still quite complex when you look at the being able to read and understand that information. So we decided that we would go out to members of the communities who weren't involved necessarily in research, but maybe had some awareness of it, and just to get a general feeling about whether the wording was acceptable and understandable. So working in research, we have lots of links up and down the country. So we wrote out to our colleagues, both in research and outside of research, and asked them to share a questionnaire with their patient or community groups, which was its sole focus was to look at whether they understood the information, whether it was acceptable to them, and would it be helpful in an information leaflet? So the majority of people, as I said earlier, came back and said it was really important, but it was very, very hard to understand what we were saying. And that's why we did this community engagement piece of work, because we were very aware of that right at the very beginning. So lots of people, there was opportunity for them to give some narrative around what they'd like to see in that statement. And we were really, really lucky with the people who responded, because they did provide us some wording as well. So taking all of that on board and looking at people's feedback and how they would like to see it change, we recreated the statement completely, and we've reduced it from a reading age of 14 to 15 right down to a reading age of 11, which is the recommended reading age for health information. And that's just so that all of our communities, whether they're English as a first language or whether they speak fluently in other languages, that it's understandable to everybody. So it was really, really good, and we're very grateful for everyone who took part in that community engagement piece of work. And we've got a much nicer adapted statement, which when we've checked, as I said, it's got a much lower reading age and it's acceptable to the communities. And that engagement work was across a very diverse community. So even though the majority were classified themselves as white British, when you look at the people we sent it to, there were representation from many, many community groups.
And I think actually, sort of as an aside, what you've said is really important, is when you're in healthcare, you forget that other people don't know the jargon and the way we say things. We can't help it if we already know stuff. You don't know what you already know. And so that sort of just strikes once again why it's so important to start talking to patients or just the general public as early as possible when you are developing or building, whether it be a medical device or a medication for somebody, how important it is to get people involved at the very, very beginning. So based on what you have found in terms of, how you phrase the beginning bit, whether it's a benefit or not a benefit, and how you say that, how do you now want to, is your aim now to try and get that across, that people can put that or should be putting that into their trial information?
Yeah, absolutely. So we would like to see that recommended in some form, and that form might look differently because we need to take into account the opinions of the ethics committees and the HRA, but we'd like a co-produced statement between members of the community, the researchers and the authorities, that we can share this information with people so that their informed consent can be fully informed, that they know what these risks or benefits, depending on how you look at this. Some people might see it as a risk, but we need to be transparent. So we would like to see this in some form in patient information leaflets across the country, and for all studies.
And it might be that what Kate's study needs to be replicated at other sites. So, I think that would be a really great outcome, is if we could look at the data that we found in Liverpool and compare that to other regions. It's no small undertaking, as you say. We had to do the kind of medical extraction of the information from the notes, and then it had an independent adjudication, myself and another consultant, to review. So it's not a small task to do, but it's a really important one.
And I was going to say, if you could make one change, what would it be? And would that be, as an example, that people have to put this into all trials, depending whatever phase they're at?
Yeah, I think that is a good goal. I think just as Kate says, to quantify it. So rather than we might find, to be able to say we might find something, and this is the likelihood of it. That's 1 in 17 people thereabouts if you're a healthy volunteer, and 1 in 25 if you're a patient. I just think that that's much easier, and we know that through the public consultation that's easier for people to kind of appreciate how likely it is. If I saw 25 people in a row, one of them we might find an extra health condition in one of those. That's easier than just we might find something else.
Well, thank you both so much for your time. And as I said, I think it's really interesting, and I think it's really interesting for the general public to understand what goes behind the scenes and how much thought goes in, how much work goes in just to change what to us, me being Joe Public, just to change one sentence. And also to make people hopefully realise the positives of going on to a trial to start with, whatever phase it might be, how positive it can be.
Great, thank you.
Thanks so much.
Thank you so much.